Hello, and thank you for watching this OncLive Peer Exchange. This program will focus on the latest research surrounding the treatment of colorectal cancer and will feature a panel of experts who will share their thoughts on how to apply the latest in research to the patients that we see in everyday practice. My name is Dr. John Marshall, and I'm a professor and the chief of the Division of Hematology and Oncology at Georgetown University Hospital, and I'm the director of the Rush Center for the Cure of GI Cancer at Lombardi's Comprehensive Cancer Center in Washington, D.C. Joining me are some of my good friends and colleagues and people I learn from every day, so I'm glad they carved some time out to join us. First, Dr. Fadi Brete, Director of GI Oncology at the Comprehensive Cancer Centers in Nevada and U.S. Oncology Research, and a Clinical Associate Professor of Medicine for the University of Nevada School of Medicine. Fadi, thanks for being here.
Thank you for having me.
Next to him, Dr. Richard Goldberg, longtime friend and colleague, physician-in-chief and professor of medicine at The Ohio State University's Comprehensive Cancer Center, as well as holding the Klotz Family Chair in Cancer Research at Ohio State's James Cancer Center and the Solov Research Institute. Welcome.
Thank you.
Good to be here, right? So finally, and not least but last, Howard Hochster, good friend and colleague, also professor of medical oncology and the associate director for clinical sciences and the director of GI cancer program at Yale Cancer Center. Howard, thanks for coming.
It's a pleasure to be here, John.
You're lying, I know already. So what we're going to do...
No, I enjoy prodding you.
We're going to get to do some of that for sure. So I kind of want to set the stage first with the new developments. We're all sitting here in Chicago before the oral abstracts for colon cancer tomorrow. We've had a peek. We've discussed them a little bit ourselves. Some of them may be practice changing, some not. Certainly some new therapies emerging, so there's a lot to talk about. And before diving into, say, the metastatic setting, let's talk about simple therapy. Let's talk about something as easy as adjuvant treatment using aspirin. Rich, tell us a little bit about that story and what we're seeing in this abstract.
So the story is from Norway, where health records include knowing all about aspirin use in patients, as well as knowing what their stage of colorectal cancer is. And what was found in about 25,000 patients is those patients who took aspirin regularly had a lower death rate due to colon cancer. They had a lower death rate in general. Mm-hmm. So not only is it good for your colon, it's good for your heart. And this corroborates findings that we've seen from cooperative group studies, from the Women's Health Study, and from other large studies that suggest that there really is a value to COX-2 inhibition in people with a history of colon cancer.
You think it's COX-2? Might be platelets, who knows?
Whatever it is, it works.
It worked.
And I use it as a part of every colon cancer adjuvant talk that I give.
Yeah. So when after patient stage 1 through 3, I'm assuming,
yep.
You would recommend that. How about for stage 4? Should we be telling them to pop a little aspirin if they can get away with it?
I think that there's some evidence that that is a good idea.
Yeah. So I take my aspirin with my bourbon every night. Do you think that would be okay?
I take mine with my simvastatin and vitamin D.
There you go. That'll be all right. So, you know, we've got a big randomized trial, Howard, right now that many of us are participating in. One of the base questions is 3 versus 6 months of adjuvant therapy. But as we know, at least in the U.S., we're doing a placebo versus 3 years of celecoxib. So more excitement about that trial and its potential results?
Well, I think that prospective trial is always stronger evidence than this kind of retrospective epidemiologic data. I mean, some of the questions I have about it, the strength is a very large sample size of 25,000, but it's a very homogeneous patient population, and it's retrospective, you know. It's based on public records, which may or may not be complete. It's a little different than doing a prospective randomized trial. So that I think will really prove this question once and for all, hopefully. If it's positive and agrees with all the epidemiologic data, then I think the questions will pretty much have been resolved.
Okay, and you too?
Yeah, I just want to also point out that right now, the Southwest Oncology Group, SWOG, is conducting a national trial, SWOG 0820, of a COX inhibitor Sulindac with another drug, DFMO, and that's for stages 1 through 3. So really a very large prevention trial. It's really looking at polyp prevention.
Yeah.
So that's another effort that's going on right now, 1,500 patient study.
Yeah, so I know there's a debate out there between, is it a baby aspirin and is it a full-strength aspirin? I don't know the answer. I've been recommending 81, baby aspirin, to most of my patients. Anybody else agree, disagree?
So I usually recommend 325, and that's partly based on the data in Lynch syndrome. And I don't think we exactly know, but I'm not sure that the toxicity of 325 is a lot more than the toxicity of 81. So one other point I wanted to make is we're almost done with the intergroup adjuvant trial. We need about 300 more patients. Now, of course, we need 3 years of follow-up.
Yeah, will we be alive when the results come out? Yeah.
I'm hoping so. That's why I take that simvastatin, vitamin D, and aspirin every day.
Yeah. So we'll be looking forward to that, and that first events we'll be seeing some PFS results, right,
Correct.
with some early OS results. You know, we were talking earlier about, Fadi, that, you know, if that study's positive, so if Celebrex is positive, and then we also have this sort of epidemiological support for aspirin, you know, are we going to need to come back and do another trial of what kind of COX-2 inhibitor? What do you think is going to be the answer there?
The devil is in the detail, and we're always worried, you know, we still remember what killed you know, other COX-2 inhibitors in the past when it comes to increased cardiovascular disease, and it's important to look at the big pictures. Yes, epidemiologic studies are very important for hypothesis generation and to stimulate physicians to put patients more on the 820 study so we can complete that study and look prospectively at other endpoints, not just at the colorectal cancer, you know, recurrence, survival, etc., but look at other health issues. You know, there is even hypothesis what's going to affect even upper GI disease when it comes to the COX-2 inhibitors. When it comes to the aspirin dose from the CAP studies, you know, I may argue for 650 milligrams aspirin too, you know, who goes higher? We don't know yet, but it's a very intriguing to look at those endpoints and evaluate. And the only way is to put them on clinical trials and to get the answer.
And the other thing is that was recently reported from the Victor study, that was the one with Vioxx before the drug was discontinued, that the greatest benefit in that trial seemed to be in patients who had the PI3 kinase mutation. So I think this is kind of the beginning. We may learn much more about molecular subsets and who will benefit from this kind of drug more than other patients. So there's still a lot to learn even after the 80702 trial is done.
Yeah, so another study.